our critical care chapter. And today's speaker, respected Dr. Jayakrishnan sir, and senior pediatricians, teachers, Dr. Purushottam sir, and most respected Dr. Thangavelu sir from Tamil Nadu, then other teachers, and my dear friends and dear students. At the outset, let me congratulate our intensive care chapter team led by Dr. Srija Sugunan for regularly conducting very useful topic. It is useful for practicing pediatrics as well as academicians and PGs. So today we are going to discuss about stabilization of a suspected poisoning. Poisoning remains one of the most common pediatric emergencies encountered in both office practice and emergency settings. First few minutes are often critical, just like any other critical care, any other emergencies. And systemic approach to stabilization can make the difference between recovery and serious morbidity. Before identifying the poison, clinician must focus on fundamentals, that is airway, breathing, circulation, and neurological status, and timely supportive care. To guide us through this practical life-saving approach, we have with us Dr. Jayakrishnan, former professor and PIC in charge, Government College Calicut, and esteemed clinician and teacher who will share his experience, the stabilization of child with suspected poison. His vast experience in managing pediatric emergencies will undoubtedly provide valuable insight that can be readily applied in day-to-day practice. So with these words, I wish all the very best for this program. Happy learning. Over to Dr. Shiju for further proceedings. Thank you.
Thank you, sir. So now we'll move on to the program. So I'd like to welcome Dr. Jayakrishnan to start the proceeding. Sir, welcome you, sir.
Thank you, Dr. Shiju, Nandakumar, and senior colleagues. And good evening, my dear friends. I'll share my, 1 second, Shiju. I'll share the screen. Is it visible, Shiju?
Yes, sir. Visible.
It's visible. Okay. I'll make it. Play mode is not coming here. I'll close it and maybe I think share it again.
Yeah, sure.
sir. Exit ചെയ്തിട്ട് രണ്ടാമതൊന്ന് കേറിയ
Exit. Okay. Is it visible now?
It's visible.
Visible at the full
Visible.
visible ആണ് full screen അല്ലെന്നേ ഉള്ളൂ.
screen.
Can see very well.
There is a problem, I think, with the full screen option here. It's coming now. Yeah, is it visible?
Yeah.
Okay, thank you.
Yeah.
Thank you very
Yes,
much.
sir, yes.
My thanks to IAP Kerala, Dr. Shrija, Dr. Nandu, and all other office bearers for this opportunity. looking at the data that we have, this actually is before COVID. It's 2015 to 2019. As you can see, majority were males admitted with poisoning in our ICU. As you can see here, paracetamol was the commonest offending drug, but then no child required extensive ICU evaluation or treatment. All of them survived. Paracetamol, higher doses ingested, but then did not require any further treatment for liver failure and all that. But then, as you can notice here, zinc phosphide and yellow phosphorus constitute a large number of cases of poisoning in our, and 2 deaths were there during that time. When we actually compared the trend of accidental poisoning in children over the last, over a period of 2 decades, in fact, we had published an earlier article in 20 years back before this, and that was compared with the data between 2015 and 19. As you can see, that there is a significant decrease in the number of children getting admitted in a tertiary care center like ours during the period compared to the period 20 years back. Most likely, many of the cases were treated outside in local hospitals. But then, as you can see here, kerosene ingestion, significant decrease again, as far as the percentage wise, you look at the number of children getting admitted with kerosene, and mortality related to rat poison was increasing. In fact, that actually is the trend even now, post-COVID also. But the immediate post-COVID period, ingestions were there, but then no significant mortality was there. But then I'll come to that again after some time. This was actually published in 2011 by Dr. Krishna Kumar. And as you can see that suicide attempts, out of 30 cases of self-harm, 25 involved poisoning. But then post-COVID, there have been cases related to hanging and all that. But then this actually is data before COVID 2011. I'll come to a case like this of a 10-month-old boy who was brought with seizures to our emergency room. Otherwise normal child, and there was no fever also. And at the time of arrival, he was unresponsive, having generalized seizures, no shock, respiratory rate was increased, tachycardia, no he was treated, in fact, with supportive measures, and chlorazepam was given and seizure was controlled. So when we took the history, we didn't know what the reason why this child had seizures. It could be due to anything, we know that, no? The reason why a 10-month-old child could have seizures could be trauma. There was no trauma. Infection is a possibility, but there was no fever, nothing to suggest infection. Metabolic problems, blood sugar was normal. And possible ingestion also. And our resident tried to do a gastric lavage after the seizure was controlled. And then she could get the smell of camphor, and that was the reason most likely for the seizure in this child. And in fact, when he got the history, the family had attended a religious puja in a nearby place. It's actually a place called Karandur near our medical college, where they had gone, and then the possible exposure to camphor was there at that time, and very likely this is camphor-related seizure. As we can, camphor in fact causes symptoms very fast. Like it gets absorbed so fast, rapid onset. So no GI decontamination methods are advised in camphor ingestion because it acts very fast, and very likely that the child can have a seizure also during GI decontamination efforts like gastric lavage. So it is not indicated. Activated charcoal again is not indicated for the same reason. And as you can see here, this actually the seizures in camphor poisoning are related to GABA mechanisms, GABA blocking, which will not respond to a sodium channel blocking drug like phenytoin or phosphonitoin. So phenytoin and phosphonitoin are drugs not to be used as a rule, maybe in all children with poisoning. If they come with poisoning, there are not many drugs or poisons which can result in seizures in children. One drug is, as we all know, is INH, isoniazid acid. Large dose injection can sometimes result in, and there are other drugs which can cause hypoglycemia, also can result in seizures. But generally, for all, practically speaking, for seizure control, phenytoin is not a drug that is to be used, that you must remember. And regarding the approach to a child with possible poisoning, anything unexplained in emergency, always suspect a possible poisoning. That's what we generally do. any sudden alteration in mental status, any respiratory cardiac compromise for which you do not have an obvious reason, any child with unexplained, again, metabolic acidosis, seizures like this child, multi-organ dysfunction, again, not having any definite reason. So anything puzzling, always think of poisoning as a cause and treat accordingly. And what we generally do, all of us do this, ask the parents to bring the medicine or poison if it is available, because we will know exactly whatever medicine exposure is there likely in the household, the environment, like the medicines taken by the grandparents or parents. You generally ask where exactly was the child found, and if they bring the medicine, we can ask them whether the number of how many tablets are missing, something like counting the pills. The volume, if the liquid that's remaining, the past history also, like if the child has a history of maybe intentional ingestion of drugs in the past, also that's important, or any other reason why this child could be having an unexplained abnormal physiology. You can get that from the past history. The medication the child is already on, developmental age, obviously, and social histories also. And when the child is brought, you always consider that the worst scenario, we would say, like all tablets available in the household have been ingested. So the worst scenario, like no significant spillage or vomiting has occurred. So whatever is there is actually causing problem. All the drugs. And suppose there are multiple children ingesting some poison, means you must assume that one child has taken all the substance and maybe treat accordingly. And the general principles, we all know this. We all do this on a routine basis. Basically, it's a supportive care. Decontamination, we'll come to that again briefly. And directed therapy, the form of antidotes, and something called enhanced elimination, which we will come to again. And the most fundamental thing, any child, any sick child for that matter, is the stabilization of the ABC. We all know that. The basic PALS principles apply here also. And the ABCDE, D stands for dextrose also. We all know that. So hypoglycemia is something that is to be ruled out in all sick children. And that's also there. And ABC care means very important that you must make sure that the child's airway is patent. Low GCS as such can result in airway compromise. It's very likely that there is respiratory depression also. And a child having low GCS with a suspected ingestion, very high chance of rapidly progressing to respiratory failure and arrest. So we need to act fast. Most of the times, an aortic intubation is needed. If that is not possible in the immediate emergency setting, a laryngeal mask airway can be tried. Sometimes oral airway might be helpful. And shock, when you recognize that, it is likely, and if you suspect poisoning, it is likely that there is significant myocardial dysfunction also. You can try giving fluid boluses, but always think of possible myocardial dysfunction and monitor the child for increasing liver size or worsening respiratory distress, and consider early inotropes. Always arrhythmia management and seizures. We'll come to that again. Seizures also how to control, we have already discussed. And the child having fast breathing with normal lung fields, quiet lung fields, very likely. And if you suspect that there is acidotic breathing, you have to be very careful. You know that it's physiologically difficult airway during the period, they can very easily go for cardiac arrest. You have to be very careful. Arrhythmia management standard principles apply here also, but there are certain situations like, for example, a tricyclic antidepressant poisoning, a sodium channel blocker poisoning. Bicarbonate is the drug that will reverse the arrhythmia. And aromatic hydrocarbon poisoning is not very common, but then where there is an increased sensitivity to adrenaline, so we have to avoid drugs like that. And beta blockers is the treatment for arrhythmia in hydrocarbon poisoning, aromatic hydrocarbon, if they have arrhythmia. And this we have already discussed. Avoid sodium channel blockers like phenytoin in seizures for all practical purposes in all children with poisoning. And barbiturates and benzodiazepines may be useful. This is one child, 9-year-old, a few years back, who had come to our ICU. Actually, was referred with history of vomiting and 2 episodes of seizures. And there was no apparent cause for symptoms initially. But then what was worrying was that 2 more children from the same locality were brought with vomiting after half an hour or so. And they said that there was a history of ingestion of thani seeds. Thani is actually an Ayurvedic medicine that we use in Kerala. We have an Ayurvedic medicine called Triphala, where Thani is one of the constituents. They use it for many, many reasons. But so Thani, people consider it to be an extremely harmless thing. And all these children were playing with this, and they are all ingested this. But then this particular child who came first, who actually had a history of seizures also on the way, had 3 hours post-admission, one more episode of generalized seizure, and then unfortunately we could not save the child. She had a sudden cardiac arrest. Other two children had no significant symptoms, and they survived. They didn't have a problem. So we didn't know what exactly was happening. But then our resident had noticed this rhythm abnormality in the monitor at that time as the child was having seizures. And obviously, as you can see, this is a void complex tachycardia polymorphic. So this most likely is related, as we know, is to long QT syndrome. The long QT, this child, unfortunately, we had an ECG of the child, and this was showing a prolonged QT interval in the ECG. And we suspected the long QT syndrome. The child is predisposed to that, and possibly this particular, maybe we don't know what exactly is there in Thani seeds, but might have actually resulted in prolongation of the QT level. Her calcium level and other electrolyte levels and all were normal. And we did genetic study for the family, sibling and father. Unfortunately, we could not get the sample of the child. Both are positive for type 1 long QT syndrome. So it is always a good idea to get an ECG in all children with suspected poisoning. It's very important. It may be PR prolongation, as we can see in digoxin and lithium poisoning are not very common nowadays. But then you have to, maybe an ECG is helpful if there is first degree AV block. QRS prolongation, there are many drugs like tricyclic antidepressants, antihistaminics like diphenhydramine, cardiac glycosides, again, digoxin, carbamazepine, chloroquine, amotidine. So many drugs are there. QT prolongation drugs are also there, like amiodarone, antipsychotics, like typical atypical antipsychotics, SSRI, macrolides, we all know, azithromycin, erythromycin, and all that, antiarrhythmics and antifungals. This we in fact had another case recently admitted, some 1 or 2 years back. Again, same Thani injection, Thani seeds, and then the child had some syncope, and then it was brought here, and the ECG was showing prolonged QT interval. So what we think is that it is possible that there are constituents in these Ayurvedic medicines or plants also, which might potentially cause prolongation of QT interval in predisposed individuals. People who we all know that the prevalence of long QT syndrome in the communities is about 1 in 2,000. So very likely the 1 in 2,000 means it's a very high prevalence. So any child who is exposed to a drug that can potentially prolong QT interval can sometimes result in significant lethal cardiac arrhythmias also. Most likely this child had that. This one, another child, 4-year-old child with ingestion of unknown number of Abrus precatorius seeds. We all know this is Kunnikuru. Brought to hospital 6 hours post-ingestion. Child was asymptomatic with stable vitals, normal physical examination. Only thing was that on day 2, we actually admitted the child. This happened 10 or 12 years back. Multiple episodes of vomiting and loose stools on day 2. Child was managed with supportive measures. And on day 4, we were actually planning to discharge the child, apparently recovering, but then suddenly the child had a sudden seizure and cardiac arrest. We don't know what exactly was the reason. Most likely the child had a cardiac arrhythmia at that time. And this type of delayed cardiac effects can happen with Abrus precatorius that you need to be careful about. So the point to be noticed is that the history of ingestion of Abrus precatorius, especially if it's crushed, swallowing of the whole Abrus precatorius seed may not be, it is not harmful, but then crushed thing, we will not get the history. But the ingestion history is there, means it's always better to monitor the child. And we don't, unfortunately, we didn't have an ECG of the child at that time. Most likely the child also had a cardiac arrhythmia. So lethal dose, as you can see, if you look at the literature, it's just 1 to 3 seeds. So even 1 seed can be lethal in an adult. And that means it can be lethal, obviously, in children also. And after supportive care, the most important thing to do possibly is decontamination efforts. So minimizing the absorption of the drug or the poison. And we need to know that the time is actually very important. Like efficacy obviously decreases as the time since exposure increases. There is nothing like routine decontamination. You don't have to do this decontamination for all children. But then if there is, there are features suggesting possible dermal or ocular contamination. It is indicated, like removal of contaminated clothing, particulate matter, flushing with tepid water or normal saline if there is obvious poison that can possibly enter through the skin. Like minimum of 10 to 20 minutes is always required. But then there are certain corrosives, alkaline corrosives and all require more longer time. Organophosphorus, we all know, requires cleaning with soap and water thoroughly. And GI decontamination is it's actually most effective in the first hour after ingestion. Beyond that, it is extremely, very unlikely that it is going to be useful. And delayed GI decontamination is something that we do only for agents which can actually cause slowing of GI motility. And if a very large quantity of the drug is ingested, like for example, sometimes in sustained release drugs, tricyclic antidepressants, opioids, and anticholinergic drugs, gastric emptying can be delayed. In such cases, you may consider gastric decontamination beyond maybe 2 hours also. And there are certain drugs like salicylate that is entry-coated, which can sometimes form a pharmacologic bezoar, which can also result sometimes, might be responding to your gastric lavage. And always remember that decontamination or subotic air is always a priority. And if the child is airway is unstable, for example, or the child is having persistent vomiting, very high risk of them aspirating into the respiratory system. And you all must remember that even the best method of decontamination will eliminate only 30% of the drugs. And gastric lavage is the first thing that you can consider for decontamination. Activated charcoal and whole bowel irrigation will come to that. And there is, as per literature, there is no documented efficacy for gastric lavage. But the problem is that in children, we are using only very small tube size, especially a nasogastric tube. So if it's a large bore oral gastric tube, which can be used in an older child or an adult, it may be of some use. And another thing is that if you waste time on gastric lavage for a child who requires otherwise definite treatment, that's also a problem. And there is always a risk of trauma, bradycardia, and most important again is risk of aspiration. Activated charcoal is most effective within 1 hour of ingestion. And there are certain poisons for which activated charcoal is not effective, like iron, lithium, heavy metals, caustics, alcohol, and hydrocarbons. But then it can be useful even repeated doses also, like for extended release tablets. Like we discussed about drugs which can cause delayed absorption. Dose is 1 gram per kilogram. So if the drug activated charcoal, again, same principles for gastric lavage apply to administering activated charcoal also. Like we need to make sure that there is an intact airway, a protected airway, and also there are no features of intestinal obstruction or any peritonitis or anything. Whole bowel irrigation for those substances for which activated charcoal is not effective. We discussed that. Like for example, iron, we can give this polyethylene glycol is a drug that we generally use 25 ml per kilogram per hour. What we do is you continue giving this infusion till the effluent that comes out is clear. And again, take care of the airway and also intestinal obstruction and all that had to be careful. Vomiting, abdominal pain, and abdominal sensation are sometimes complications that can be seen. Then comes after the supportive therapy, decontamination. The third step is always look for an antidote that is available. If there is an antidote, the earlier you use the antidote, the better. And then intravenous lipid emulsion therapy will come to that again. So there are certain drugs for which antidotes are readily available, like iron, we all know, deferoxamine, dapsone, methylene blue, morphine, naloxone, organophosphorus, atropine, paracetamol, N-acetylcysteine, we know that. But then rat poison, possibly N-acetylcysteine is useful. We'll come to that again after some time. Calcium channel blockers, calcium and insulin. There are many other drugs also. You can always it is at this point, in itself, maybe I need to emphasize the importance and usefulness of poison control centers in our country. Poison control centers are there in AIIMS. It's there in Vellore. It's there in Amrita Institute of Medical Sciences in Kochi. So all the poison control centers, they respond very promptly, and it's always a good idea to contact the poison control center if you have any doubt regarding management of poisoning. Intralipid emulsion therapy, another form of drug-directed therapy, like for example, specific drug which are fat soluble, sometimes poisoning might respond to intralipid infusion therapy, calcium channel blockers like verapamil, LTSM, amlodipine, tricyclic antidepressants, and then very large quantity beta blocker dose. That also, an refractory beta blocker overdose. The same solution that we use for total parenteral nutrition, that's 20% lipid solution, is used, 1.5 ml per kg. We're giving it over 3 minutes initially as a bolus, and then we're giving it slow. Total of 10 ml per kilogram. And after this directed therapy, then you consider ways to maybe like urinary alkalization. That's for enhanced elimination. Hemodialysis or multiple dose charcoal, again, we'll come to that. Urinary alkalization for drugs which are acidic, mildly acidic, sometimes might respond to alkalizing the urine. What you can do is continuous infusion of sodium bicarbonate can be given, but not, it's only very few cases of poisoning we use this. You need to have a target urine pH of 7.5 to 8, monitor serum pH always, not to exceed 7.55. Watch for hypokalemia, hypocalcemia during the infusion. And if there is only fluid overload, you need to be careful. Contraindications are there. And for drugs like methotrexate and salicylate poisoning, urinary alkalization may be useful. Hemodialysis generally is not a recommended modality of treatment in poisoning, considering the risk and benefit ratio. It may be useful again in certain situations like methanol, ethylene glycol, valproate, salicylate, lithium, and all that. And lactic acidosis, related to metformin. Another thing like for activate, enhanced elimination, multiple dose activated charcoal can be used, like 0.5 gram per kilogram is the dose. We initially give for activated charcoal the dose of 1 gram per kilogram. Then after that, 0.5 gram per kilogram every 4 to 6 hours for 4 doses. Activated charcoal is nowadays, it is available through our government, in government hospitals, available as a powder. It's there in certain medicines also, which are used for J issues, we know that preoperative preparation, all that. So activated charcoal is available. The way it acts, the multiple dose activated charcoal acts is actually by interruption of drugs which come back to the intestine through enterohepatic circulation. And sometimes these activated charcoal that is there inside the intestine will act like a dialysis, GI dialysis. The intestinal mucosa acting as the dialysis membrane, and that will actually result in elimination of the drug. Significant ingestion of carbamazepine, dapsone, phenobarbital, and theophylline may respond to multiple dose activated charcoal also. This was a 3-year-old child who actually was referred from a local primary health center with an unknown quantity of iron tablet injection 2 days back. In fact, the child was very sick, moribund state, responding only to pain. Respiratory rate was 12 per minute, shallow breathing. Child was in respiratory failure at oxygen saturation, 80%, fast heart rate, shock, hypotensive, cardiopulmonary failure. And child was very sick, severe metabolic acidosis. The usual supportive measures were given, mechanical ventilation, but then unfortunately, we could not save the child. Iron poisoning. So iron poisoning 2 days back. In fact, what happened was the tablets were supplied to the pregnant mother from Anganwadi. And then unfortunately, the child consumed a large quantity. And the child had GI symptoms. Within 3 hours, 3 hours after the injection, child actually had multiple episodes of vomiting and loose stool. They had gone to the primary health center, treated there with IV fluids. Child was symptomatically, there was improvement. There was no symptom after 3-4 hours, and they discharged the child home on the same day. And after 24 hours after that, child was brought to us in cardiopulmonary failure. We'll come to that again. So this is our data of iron poisoning last 10 years. No, not 10 years, more than that, 15 years almost. As you can see, there was a peak, 2007 and 2008, large number of children used to get admitted with iron poisoning at that time, and we had many deaths. In fact, 28 deaths at that time during that period. In fact, that was a time when Anganwadi teachers used to give loose iron tablets. But then after that, there was a lot of discussion happening even in our IAP circles regarding this. And we actually had many meetings with our neighboring district medical officers also in many of the districts. And finally, this actually awareness classes were given for Anganwadi teachers. And you can see that there is a dramatic decrease in the number of cases of iron poisoning getting admitted. Only in 2021, we had some more deaths. I mean, one 1 or 2 deaths, I think, that time. That was actually the peak of COVID season, and no proper management was available at that time, possibly. That is the reason why this unfortunate death happened. But then, as you can see, that there is a dramatic decrease in the number of iron poisoning cases. So what we need to remember is that initial GI symptoms can be there during the first 3-4 hours, and then there's a period of apparent stabilization in iron poisoning. And we need to be very careful that GI symptoms are there following iron ingestion, means that child needs to be observed, because there is a very high chance that significant iron poisoning can happen. This particular child who I was talking about, unfortunately, the treating doctor actually sent the baby child home, and the next day the child came with multi-organ failure. So symptoms subside after apparent stabilization after 3-4 hours, that you need to remember. And all multi-organ failure, mitochondrial toxicity, and all that will happen after 24 to 48 hours. So, and indication for assessment of iron poisoning is actually the quantity if it's more than 40 mg per kg. Unknown quantity, again, you need to be very careful. Like what happened in this child. Any child who is symptomatic, always admit and evaluate. Bowel decontamination is by gastric lavage within 1 to 2 hours of ingestion. What we do is we sometimes may do gastric lavage even beyond that. We have seen many children having delayed gastric emptying with actually iron tablets visible in the X-ray abdomen even after 2-3 hours. So we do gastric lavage even after that. And whole bowel irrigation, as you know, activated charcoal is not effective in this poisoning, iron poisoning. If there is visible X-ray and if there is ingestion of more than 60 mg per kilogram of ingestion, and if you are not sure about the quantity of ingestion also, we generally would give whole bowel irrigation. And fortunately, there is an antidote available. Deferoxamine is the antidote. And severe GI symptoms, the child has acidosis. Acidosis is a very useful lab finding. Always, if possible, get a blood gas analysis done. If there is acidosis, we generally treat them with deferoxamine. During the period of acidosis, there may not be any symptom also. Initial GI symptoms are there, but then symptoms subside. At that time also, if you do an ABG, acidosis may be a subtle indicator of significant ingestion. And that's an indication for deferoxamine. Obviously, coma, seizures, and all that. If iron tablets are visible in the abdominal X-ray, treatment, it's better that you treat with deferoxamine. Serum iron concentration, if you can do that, more than 90 micromole per liter. Or if the child is symptomatic and if it is between 60 and 90 micromole per liter also, treatment is indicated with deferoxamine. And how long to continue on deferoxamine is an issue always. So, generally, the child is asymptomatic, the acidosis is resolved. Serum iron is less than 60 micromole per liter. And urine color may not be very useful always, but then very large quantity ingestion, if you treat the child with deferoxamine, urine color, the classically described wind rose color can be there. And generally, you do not continue treatment beyond 24 hours, that you must remember. Paracetamol, we all are familiar with, but then this type of preparation is the problem here, that because of the moment this was introduced a few years back, some 10 or 15 years back, I think, we started getting cases related to this. So it's very high concentration. Even 1 gram is available now, I think, for liquid. But then you need to be, I think, careful about this. Again, only thing that I need to maybe remind you is that, again, for this also, there is an asymptomatic period after the initial period. Another thing I forgot to mention about iron poisoning was that if they do not have GI symptoms in the first 6 hours, you can easily maybe counsel them regarding the chance of poisoning is extremely low, and maybe you can even send the child home. So first 6 hours, they do not have GI symptoms. I'm talking about iron poisoning. For paracetamol poisoning also, you can see that there is a symptom-free period. We all know this. But then always remember that in a significant quantity ingestion, which is not very common nowadays, paracetamol, if you give the specific drug, that is N-acetylcysteine, within within 8 hours of ingestion, practically there is no chance that the child will have liver failure. So within 8 hours you can, but even beyond 8 hours also you can use N-acetylcysteine. There is no lab available in our place. Maybe I think many places in India where paracetamol levels are available within a reasonable time. You do that today and then you will get the result tomorrow. Means there's no meaning in getting a paracetamol blood level to decide regarding the need for N-acetylcysteine therapy. We do not routinely use the Rumac-Matthew nomogram for paracetamol toxicity. What we do is we start treatment if there is a history of significant ingestion, like if it is more than, obviously, as per algorithm, this is acute ingestion more than 200 milligram per kilogram of single dose, ingestion of an unknown quantity, and repeated ingestion again more than 100 milligram per kilogram per day. Practically, we can try giving this N-acetylcysteine always, because extremely safe drug, I would say, N-acetylcysteine. If you are giving it intravenously, there is a very rare chance of anaphylaxis, but again, we have not experienced that. Oral amoxicillin is, oral N-acetylcysteine is equally effective. That can also be given. What we do is, even if the ingestion quantity is a little less, like around 100 mg per kg also, we generally treat them with N-acetylcysteine in children who are malnourished, in children who have high fever, because high fever, severe wasting and all are conditions where there is a higher likelihood of liver toxicity with paracetamol, even with lower doses. So this 200 milligram per kilogram, as per Western literature, may not be applicable to all children who have acute severe malnutrition and all that. Multiple supratherapeutic injection, like if it is more than 200 mg per kg or 24 hours, 150 or 48 hours, or more than 100 mg per kg per day or 72 hours also, you can consider giving an N-acetylcysteine. Okay, this one is a 5-year-old boy with a history of ingestion of black powder. So actually, they did not know what the powder was, but then they brought this small green container, and we didn't know what exactly was the content. Child was stable at the time of arrival. We did all the investigations, LFT, RFT were normal, ECG was normal, blood count, everything was normal. Third day, we discharged the child, but then we considered the possibility of zinc phosphate also. We had seen zinc phosphate being marketed in this kind of small green containers. So we considered the possibility of zinc phosphate injection, suspecting this thing. But then, so we asked them to review again after 1 week, and repeatedly they had come every week. But then second week, third week, they come. But then on 25th day, he was brought with, child was asymptomatic, his liver function, all RFT, everything was normal. But then 25th day, he was brought with jaundice, encephalopathy. We could not save the child. In fact, he had severe end-stage liver failure by the time he came and expired. So this, and on further questioning, the father told that he actually had purchased rat poison. This is most likely zinc phosphate. And the point to remember is that zinc phosphate can sometimes have delayed poisoning also, like this, after 2 or 3 weeks also. Another child, again, a rat poison, that is ratol paste. Very sick child, increased workup within cold extremities, hypotensive shock, respiratory failure. This we could not save the child, and a large quantity injection, especially yellow phosphorus. That is, this ratol contains yellow phosphorus. The zinc phosphate is the other one. This one is yellow phosphorus. Yellow phosphorus is more dangerous. So that can, in the initial period, early on, they can have cardiac arrhythmias. That is, the child had all the problems, cardiac arrhythmias, and then multi-organ failure also on the same day. And then, unfortunately, we could not save the child. This is a very high concentration of yellow phosphorus. In fact, this is something which needs to be, the health authorities need to take and consider, maybe having at least a warning here that this is an extremely dangerous thing. This looks like a toothpaste. We had cases coming to us with children mistaking this for toothpaste and brushing their teeth and then having liver failure. So this can happen. It's freely available in the market also. It's a problem. Yellow phosphorus, again, like we discussed about iron poisoning, can have a period of asymptomatic period. Zinc phosphate also we discussed, asymptomatic period is always a problem. But then during the asymptomatic period, generally, most of them, yellow phosphorus poisoning, have mild elevation of liver enzymes and liver and hepatic failure and MODS, that's the usual thing. And fatal dose in adults is 1 milligram per kilogram. Can cause easily death in children. N-acetylcysteine, we do use that, but then in isolated case reports, it's mentioned that many people have found this to be useful, N-acetylcysteine in children with yellow phosphorus or zinc phosphate poisoning. We do that. We use that. Therapeutic plasma exchange in significant poisoning nowadays. A lot of centers practice this, and liver transplant if there are indications. This one, a newborn baby, cried at birth, 2.5 kg, started breastfeeding and all that. Difficulty breathing and jaundice was noticed around 48 hours of life. Some difficulty breathing was there. On examination at 48 hours, child was irritable, having increased respiratory rate. Central cyanosis was a prominent feature. Saturation was 84% on oxygen. Somebody did an ABG, which was normal. PaO2 was 140 millimeter. Bilirubin was high, 24 milligram per dl. On further reviewing the history, after birth, the baby was wrapped in sheets and made to wear clothes kept in a cupboard with naphthalene balls. So most likely there was naphthalene poisoning because the child was having an obvious cyanosis with the oxygen saturation by pulse oximeter of 84% with a normal PaO2. So normal PaO2 and a low saturation in the range of 84, 85 always indicates methemoglobinemia. And with this history of contact with naphthalene balls, it was actually suspected. Child required double volume exchange transfusion, and the methemoglobin level was estimated 15%. So methemoglobin level, nowadays our modern blood gas machines all give the report with the methemoglobin level in that. If that is there, well and good. Otherwise, it is sometimes difficult. There are pulse oximeters where echo oximeter is also available, where you can actually get this methemoglobin level. Otherwise, it is not freely available. So methemoglobin anemia is a condition that needs to be always considered in any child presenting with exposure to possible naphthalene ball or any other drug. We'll come to that again with another case. Methemoglobinemia is a problem with naphthalene ball poisoning. Intravascular hemolysis as such is another thing that can happen, like what happened in this child. And related to pigments, they can have AKI also. And the amount of naphthalene in each ball varies. But then the pediatric lethal dose reportedly is around 2 to 3 grams. So it can be sometimes lethal, that you need to remember. A value more than 5% is considered as abnormal always. It's called methemoglobinemia. Normal is less than 1%. You must remember that. So 5% is significant, more than 5%. Symptomatic, they become if it is more than 10%, and it is life-threatening if it is more than 30 to 40%. This particular child, actually, what we do is we actually need to discontinue whatever drug that is given, which can possibly cause methemoglobinemia, and remove the offending thing like naphthalene ball and the clothes in this particular child. And more than that, and the exchange transfusion we did not give any specific antidote. And pulse oximetry we already discussed, like it will result in a fixed SpO2, like it's around 85%. So if it is 85%, generally 85% saturation will not cause insignificant cyanosis. Unless the child is really polycythemic, like so, it can be there in newborn. But then, if there is in disparity, like 85% child having severe 85% saturation with severe cyanosis, means again, even without an ABG, you can maybe suspect methemoglobinemia. And if you give supplemental oxygen, there is no improvement. Normal PaO2 and ABG. Another child, actually, this child was admitted in our oncology ward with a very high leukocyte count. Child was having ALL. The child was having a high uric acid level also. The treating oncologist actually treated the child with, as you know, like hyperleukocytosis. They treat with high fluids, and raspberry case also was given. But then just within maybe 30 minutes to 45 minutes of starting this drug, child actually had severe respiratory distress. So much agitation also. And then, in fact, our oncologist, Dr. Sheetal, brought the child to our PICU from the ward running, and child was having... Child was very sick, like central sinus also was there. SpO2 again was 85%. No improvement with in SpO2 with oxygen, and heart rate was 160. With raspberry case, this was our first experience a few years back. This again, raspberry case is well known to cause methemoglobinemia in children who are predisposed. You know that children who have G6PD deficiency are very highly likely to have this complication, can result in intravascular hemolysis also. And this we have already discussed, like the disparity between pulse oximetry and ABG. And the drug that we can give in such situations is the methylene blue. But then the problem is that it is contraindicated in GCPD because methylene blue is a reducing agent, which can result in significant hemolysis. Ascorbic acid can be tried for treatment. In this particular child, we used that. We treated that with ascorbic acid. Uric acid converts uric acid to allantoin. You know that, no? It acts by converting uric acid into allantoin. In that process, there is a lot of production of hydrogen peroxide, which actually can result in oxidant injury. That's the basic problem. Actually, in healthy people, G6PD is there means it produces NADPH which neutralizes hydrogen peroxide. So G6PD deficiency is there means this hydrogen peroxide can be very harmful. It can cause methemoglobin, and this oxidant injury can also cause some significant hemolysis also by injury to the RBC membrane. So significant hemolysis and severe methemoglobinemia can be there in raspberry case. So it is actually, it should be a practice. We have actually started doing that to rule out G6PD deficiency in all children who you are going to treat with raspberry case. This we have already discussed. Elevated this cyanosis saturation gap means we need to consider possible G6, methemoglobinemia in these children. And these are the drugs. There was a recent review, in fact, this recent study, I think, retrospective study where they found dapsone to be the commonest drug. Nowadays, dapsone is used for many indications in children also. So there is a very likelihood that can come with significant dapsone poisoning, which can result in methemoglobinemia. And if you can reasonably rule out G6PD deficiency, methylene blue is a treatment which can save the child. You must remember that it's very cheap. It used to be, it is easily available now, but then previously it was not that easily available, this methylene blue, but nowadays it is available. You can use it, methylene blue. Topical anesthetics, like if you use that, like lidocaine and lignocaine, topical, or sometimes inhalational topical anesthetics for scopy and all that. If you use in a child who is predisposed G6PD deficiency, they can have severe methemoglobinemia. Naphthalene blocks we already discussed. That's raspberry case. There are many other drugs like antimalarials and all that. Nitric oxide and all that, but these are the common drugs that we see. So immediately discontinue the drug, sabotage care, and rule out G6PD deficiency in children who you are going to treat with methylene blue. Generally, only if the level of methemoglobin is more than 30%, they require treatment. Otherwise, treatment may not be needed. If they're symptomatic, you may have to treat it. Ascorbic acid is another drug that can be given. So this is the last slide. Very important. These general principles we all know, but then many people don't practice. All poisons out of reach. Safety tops and all that. In fact, the US, when they introduced the safety tops in children, in all drugs for children, significant reduction in the number of poisoning in the cases they have documented. Tightly closed up. But the problem nowadays they face is that old age people, they themselves find it very difficult to open the containers. So what they do is they open the container with difficulty and then put everything into an easily openable container. So that is the reason why many children get exposed to toxic drugs nowadays in the US. Okay, thank you very much. Thank you for the opportunity.
Dr. Shiju is there. Shiju is not there.
I'm not able to stop sharing. It's what I'm looking for.
Sir, I think there are a few questions in the chat box. അത് വായിക്കണോ സാറേ അതോ
വായിക്കാം ശ്രീജ, ഞാനത് കാണുന്നില്ല. Questions.
First one, how frequently?
Shrija?
Sorry, the first question is how frequently to monitor serum iron?
Yes.
In iron poisoning, how frequently to monitor serum iron?
We don't generally base decision regarding stopping nephroxamine infusion based on serum level. What we do practically is we do it only once initially. If it is more than 90, we generally start treatment. We don't rotate because generally not more than 24 hours this is given nephroxamine. So based on serum level alone, you cannot make a decision. So you don't generally do that.
Sir, on the same topic, they have asked, also, can you elaborate a bit on the procedure of whole bowel irrigation?
Whole bowel irrigation, PEG is easily available now. So you can use that. You put in a nasogastric tube always, and give this as an infusion. It can be given 25 ml per kilogram per hour is the dose that is given. You continue giving that. Generally, it is not absorbed. It definitely is not associated with any electrolyte imbalance also. Till the effluent is clear, you continue giving the rectal effluent.
So, but then there's a comment that therapeutic plasma exchange appears to be life-saving in rodenticide poisoning. It's from Thangavelu, sir. Sir had to leave early because he had some other engagement. So he had commented that.
Yes, people are doing that on a regular basis now. Significant rat poison injection, it is life-saving.
So we used to have many cases of rat poisoning before, and we also had deaths. And usually, sir, പറഞ്ഞ പോലെ ഒരു unexpected arrhythmias were what we would see. Like asymptomatic the patient would be, and then suddenly going in for an arrhythmias, especially with this yellow phosphorus.
Yellow phosphorus.
As sir said, the hepatic failure often took time to manifest. It was like that we saw. But then we had done a study, and what we found was patients who had metabolic acidosis was one of the earliest signs of them.
Yes, Shrija, I remember reading that paper. Yeah. Hello? Shrija, you're not
going in for a cardiac toxin. So now go for a periodic monitoring of the blood gas treatment according to that. That means your magnesium, NAC, and round-the-clock bicarb goes. And usually the earliest ECG changes that we used to see was a global T-wave inversion. And then it would go for any kind of thing. Any such experience there? Have you noticed such a phenomenon?
Shrija, only one child who actually died in 2021 post-COVID. I mean, during the COVID season. This child had a large quantity injection and had all cardiac T-wave changes were there. ST changes were there. And
I do not. I do not know, sir. നമ്മുടെ ഈ protocol beneficial ആണോ എന്ന് അറിയില്ല. But anyway, for the last 5 years, we've not had deaths with rodenticide poisoning.
Very few deaths.
Maybe more than 5 years. And I still remember our Reshma endocrinologist, every time she had taken the ICU as a first year, second year, third year, all 3 years she had witnessed rodenticide death.
Yes.
So I think maybe we can also look at metabolic acidosis. That seems to be one of the earliest manifestations of toxicity, because it's basically a mitochondrial toxin, the phosphine gas goes there. So that is one thing I think we can look at. Sir, another question is how to manage a child who has ingested camphor.
Camphor acts very fast. Within 30 minutes, it can result in symptoms generally. So it is it's actually the only treatment that is possibly symptomatic. By the time they are brought to the emergency, they have seizures. So it is maybe, I think, gastric lavage, as I told, GI decontamination is not effective. And majority of them, I think, results are extremely good if you treat symptomatically with anticonvulsants. That is lorazepam. Avoid phenytoin.
So there's one question that they wanted to comment on kerosene poisoning, maybe because that's quite common even now. Maybe that's right.
Yes, it is very common now after I think the war, Gulf War. That's what we think. Now it will be very low, the incidence, but then suddenly last 2 months, and the number has increased like anything. When we asked, many of them said they keep this mananavalka also in their household nowadays. That is one reason, possibly. And what was the question like, Shrija?
So basically management. നമ്മൾ cover ചെയ്തില്ലല്ലോ sir എന്നുള്ളൊരു. Just wanted to know how to manage a kerosene poison. Kerosene ingestion, accidental ingestion.
Kerosene ingestion, if they are not, we do not know. Generally, what we see is immediately following ingestion, they are very much symptomatic. Like possibly there is some absorption taking place that results in CNS involvement also. They look desperately ill, like immediately following. So like in a peripheral hospital, if you are working and then suddenly the child is brought, we would feel like this child is going to die at any moment. Like, but then within a few minutes, generally maybe around 30 minutes or so, child, that sensorium will improve, respiratory distress will improve. The problem is that if they vomit, there's a very high chance of them having this aspiration pneumonia. That is one thing. What we do is we observe the child for 6 hours at least. Generally, that's the time when they have these symptoms related to chemical pneumonitis happening. If they are symptomatic, we can maybe get an X-ray done to document chemical pneumonitis. But before that, if they are not symptomatic, there's no point in getting an X-ray done. That is one thing. And antibiotics are not useful in respiratory distress related to kerosene ingestion. And another thing is that chemical pneumonitis is something which can result in intermittent periods of high fever and respiratory distress, which can occur maybe for many days following the ingestion. We have seen that happening in up to 1 to 2 weeks sometimes, chemical pneumonitis. So most of the cases, majority of them do not need antibiotics also.
I think, sir, that's the one more question.
Any more points you need to
I
tell?
think, sir, no, sir,
Yeah.
there's no more questions. A lot of comments of excellent session today. So that was a really nice session, sir.
Okay.
Purushottam sir.
Clear. So
Purushottam
I
sir.
think I'll ask Purushottam sir. Purushottam sir.
Yeah,
As
after
usual.
Purushottam sir first.
Can you hear? കേൾക്കുന്നുണ്ടോ?
Yes.
അതെ sir, കേക്കുന്നുണ്ട്.
Sir, audible ആണ്.
As usual, as expected. If you experience, Gobia was asking about the camphor, and in 90s, Dr. Shrija was there and Gobia was there. There was a Vaidya family, Mullili Thailam, and that was being
Yes,
given
sir.
for asthma. And at least once in a week, we used to get the kids with analyzed convulsions. Within a matter of hours, it would be getting settled. So after that, the camphor poisoning a little less. And one more experience we had during the late 90s was the shellfish poisoning from the Vilignum. And there were many
sir.
cases of deaths at that time, saxitoxin. Some of the seasons, the sea will be showing some color, and at that time you should not be taking that shellfish. And following that, one of the I think it was 1998 or so, many cases admitted adults, kids, and a few kids died during that time. Recently, again, I think in 2026 February, there were a few deaths following the eggs of the puffer fish. Puffer fish എന്ന് പറയുന്നൊരു ഫിഷ് ഉണ്ട്. That should be removed when they are catching it. The fishermen know that fish cannot be taken. And the egg of a few more of these things is very highly neurotoxic. That is tetrodotoxin. So that happens. So what is to be considered is there may be a change in the pattern of this algae with the environmental change in the sea. So we should be expecting more and more of this sort of a fish-related neurotoxicity in the coming years. One more point again, that was in the 80s. We had this cyanide poisoning from Nenmara, Vallangi. At that time, the whole thing was a generator. Generator അടുത്ത് കടന്നുറങ്ങി പോയ ഒരു കുട്ടിയായിരുന്നു. By the time he was brought in coma, we couldn't say at that time. With the difficulty, we could get an MRI done where the basal ganglion changes were there. At that time, the spectrophotometry was done, and nothing, hyperbaric oxygen exchange, all mentioned, but we couldn't do that. We couldn't save the child. So in the present context, we need to consider cyanide poisoning, because they used to keep babies inside the car and leave during the that is one thing which we need to be considered. Another thing is in the ground floor of the theaters, ground floor of the cinema talkies and all, lot of vehicles getting parked, and within 5 minutes, not many cars will be racing, and the baby should not be taken to the underground. So carbon monoxide poisoning also we need to consider. Many of the plant poisoning were there at that time. The spectrum of poisoning has changed. The first slide I was considering when how the iron poisoning has come down. And one more poisoning we had was dapsone poisoning with methemoglobinemia. Nowadays that was also coming down. dapsone poisoning was quite common at that time. I think it is because of the blister packets and the national program and all very careful there. It's nowadays less. The breast poisoning also we had a late fifth day cardiac toxicity and dying. At that time, odolum, oleander, and the pacemaker insertion and all were. But nowadays it has all come down. The plant poisoning also. Nowadays, a harmless thing like Jatropha and all are coming with the simple vomiting and all. Not much of other the plant poisonings. So I read about the N-acetylcysteine use. Pangaveli sir, I wanted to ask about his experience. I had heard a talk. Many cases they use this N-acetylcysteine, and that was working well. Our experience.
We
Not
use that on a routine basis, N-acetylcysteine, and possibly it is effective. That's but there are case reports, many case reports where the found to be useful. We use that. Polyethylene used to be very common when we were doing PG in SAT in 1988. Dr. Jayakumar did a thesis on that, polyethylene poisoning.
The ratol is very dangerous because, as you said, by mistake, one kid was using it as a paste. There was a family from Guruvayur just before I retired in 2021. One family, the suicidal.
Yeah.
The whole family died one by one. 3 kids were given, father, mother, all died with the same method.
That
The
particular,
excellent.
this packaging needs to be banned, sir. This ratol. That toothpaste, like, it is dangerous.
I think we should, Nandamar, we should be
Yeah.
giving, maybe at the national level, we should be giving a recommendation of this, the packing of this thing, and mineral water, battery water is packet in a mineral water, the paste form with many of the poisons, and the composition of the drugs, paracetamol 500,
Yeah,
paracetamol
paracetamol 500
1 gram,
dangerous.
and vitamin D also. Vitamin D, even though it is not producing an acute poisoning, we had cases after 3 months developing renal calcification and polyuria. So all these things, I think we should be giving a recommendation. What all causes are causing the kids poisoning and dangers. So unless we make them aware of this problem, complete out. Thank you, Jason. Excellent talk.
Yeah, as excellent as expected, and it was really a very good talk, which is very useful for all pediatricians. And one more doubt I have, this is about thyroxine. This is also a very common thing which we have seen. It is also a late poisoning. So we have to observe for long period. So what is your experience and what is your advice regarding that?
Thyroxine, generally, even large quantity ingestion is usually that's not very toxic. But then can have very long half-life, and as you, Dr. Nandu mentioned, can have problems. Child needs to be observed, but then we have not found any. We did
Actually,
not have any.
how long you have to this
Up to
observe
6
that?
days, I think. I'm not.
It's cardiac arrhythmias and common.
I have not experienced it.
Okay. Dr. Shija, do you have any experience?
Yeah, we do come across a lot of patients coming with the thyroid, but as sir പറഞ്ഞ പോലെ അങ്ങനെ symptomatic ആയിട്ട് we haven't seen.
Okay.
Usually they say by 3rd day only you're expecting this thing, but usually arrhythmias അങ്ങനെ symptomatic ആയിട്ടില്ല.
Okay. So I once again congratulate our team, critical care, for these excellent programs they are conducting regularly. Dr. Shija, you can conclude, I think. Because if there are no more questions, I think we can conclude.
Dr. Sebastian ഉണ്ടോ? I think it's not there.
No one else is there.
ഞാൻ തോന്നുന്നില്ല. So thank you, Jayakrishnan sir. It was an excellent session, very useful. I hope it was very clear. As usual, your rich experience contributed to the knowledge that you shared with all of us. Thank you for joining us today, sir. Thank you, sir.
Good night.
Thank you very much.
Good night.
KGA സംസ്ഥാന പ്രസിഡന്റ് ടി ഷൈനി ആന്റണി, സംസ്ഥാന ട്രഷറർ എൻ പി സുധീഷ് കുമാർ, FSETO ജില്ലാ സെക്രട്ടറി ഇ നന്ദകുമാർ, കോൺഫെഡറേഷൻ ഓഫ് സെൻട്രൽ ഗവൺമെന്റ് എംപ്ലോയീസ് ആൻഡ് വർക്കേഴ്സ് ജില്ലാ സെക്രട്ടറി ഐ പി ശ്രീകുമാർ, KGA സംസ്ഥാന സെക്രട്ടേറിയറ്റ് അംഗം ആർ സുരേഷ്, അബിൻ രാജ് തുടങ്ങിയവർ സംസാരിച്ചു. പാലപ്പുഴ രാപ്പാട് പള്ളത്ത് ശക്തമായ മഴയിൽ കുറുമാൻപുഴയുടെ വൻപിടി പുഴ ഗതിമാറി കൊടുക്കുമെന്ന ആശങ്കയിൽ മാറുക. ബണ്ടിനോടൊപ്പം പുഴയോരത്ത് നിന്നിരുന്ന 2 വള്ളങ്ങളും പുഴയിലേക്ക് പതിച്ചു. 15 മീറ്ററോളം നീളത്തിലും 6 അടിയിലേറെ ആഴത്തിലുമാണ് ബണ്ടിരുന്നത്. മഴ ശക്തമാകുന്നതിന്റെ വെള്ളമുയർന്ന് പുഴ ഗതിമാറി ഒഴുകുമെന്ന ആശങ്കയിലാണ് നാട്ടുകാർ. പുഴയ്ക്ക് പുറകെ വീണ് കിടക്കുന്ന മരങ്ങൾ ഒഴുക്കിന് തടസ്സമാകുമെന്നും ബണ്ടിരുന്ന ഭാഗത്തേക്ക് വെള്ളമെത്തി കൂടുതലായി പറയുന്നു. പുഴ ഗതിമാറി ഒഴുകിയാൽ പ്രദേശത്തെ വീടുകളിൽ വെള്ളം കയറും. ബണ്ടിലെ ഒരു വശം പുഴയിലേക്ക് ഇടിഞ്ഞതോടെ ബണ്ടിന് ബലക്ഷയം സംഭവിച്ചതായി നാട്ടുകാർ പറയുന്നു. ബണ്ട് തകർന്ന 100കണക്കിന് വീട്ടുകാരെയാണ് ബാധിക്കുക. 2018 പ്രളയത്തിൽ ഈ പ്രദേശത്ത് ബണ്ടിന് പുഴ ഗതിമാറി ഒഴുകിയിരുന്നു. തുടർന്നുള്ള വർഷങ്ങളിൽ പുഴ കവിഞ്ഞൊഴുകുമെന്ന ഭീതിയിൽ വീട്ടുകാർ മാറി താമസിക്കുകയാണ് പതിവ്. ബണ്ടിന്റെ ഭാഗത്ത് മണൽച്ചാക്കുകൾ കൊണ്ട് താൽക്കാലികമായി ബണ്ട് കെട്ടണമെന്നും പുഴയിൽ വീഴുന്ന മരങ്ങൾ എടുത്തുമാറ്റണമെന്നുമാണ് നാട്ടുകാരുടെ ആവശ്യം. കോർഡിനേഷൻ കമ്മിറ്റി നിവേദനങ്ങൾ കേരളത്തിലെ പരമ്പരാഗത വെടിക്കെട്ടുകൾ സംരക്ഷിക്കുന്നതിന് വേണ്ടി പെസോ നിയമങ്ങളിൽ ഭേദഗതി വരുത്തി സുരക്ഷിതമായ വെടിക്കോപ്പുകൾ നിർമ്മിക്കാൻ നിർമ്മാണ യൂണിറ്റുകളുടെ ക്ലസ്റ്റർ രൂപീകരിക്കണമെന്നും സുരക്ഷിതമായ വെടിക്കെട്ട് നടത്താൻ സൗകര്യമുള്ള സ്ഥലങ്ങളിൽ വെടിക്കെട്ട് നടത്താൻ അനുമതി നൽകണമെന്നും മാഗസീനുകൾ നിർമ്മിക്കാൻ തണ്ണീർത്തറ നിയമത്തിൽ ഇളവുകൾ അനുവദിക്കണമെന്നും ഫെഡറൽ കോർഡിനേഷൻ കമ്മിറ്റി ആവശ്യം. സംസ്ഥാന വർക്കിംഗ് പ്രസിഡന്റ് എ കുമാരൻ, ജനറൽ സെക്രട്ടറി വത്സൻ ചമര, സംഘടനാ സെക്രട്ടറി തരുൺ ബാബു, സംസ്ഥാന എക്സിക്യൂട്ടീവ് അംഗം കെ മഹേഷ് എന്നിവർ നിവേദനത്തിൽ തൃശൂർ ലത്തീപ്പള്ളി വിശുദ്ധ അന്തോണീസിന്റെ തിരുനാൾ ഭക്തി സാധനമായി കോടപ്പുറം ബിഷപ്പ് ഡോക്ടർ ആൻഡ്രൂസ് പുത്തൻവീട്ടിൽ ഊട്ടുനേർച്ച ആശീർവദിച്ചു. തുടർന്ന് നടന്ന ദിവ്യബലിയിൽ ബിഷപ്പ് മുഖ്യ കാർമ്മികത്വം വഹിച്ചു. ആയിരങ്ങളാണ് ഊട്ടുനേർച്ചയിൽ പങ്കെടുത്തത്. കേന്ദ്ര സർക്കാരിന്റെ കൃഷി കർഷക ക്ഷേമ മന്ത്രാലയം ജൂൺ 1 മുതൽ 30 വരെ രാഷ്ട്രീയ വ്യാപകമായി നടപ്പിലാക്കുന്ന ഖേത് ബച്ചാവോ അഭിയാൻ പ്രചാരണ പരിപാടിയുടെ